Passing the National Medical Licensing Examination is the final hurdle for every medical student, but the sheer volume of material expected is often paralyzing. To manage this, you need more than effort. You need the definitive architectural blueprint that now dictates exactly how this test is constructed. This is Decision Number 22, issued by the National Medical Council. It is the official directive detailing the format, the required competencies, and the exact weightings of the exam. And as the text specifies, this framework applies directly to medical doctors. This document is the official standard. Following it is the only way to ensure your study time aligns with how the council will score you, no matter how much textbook knowledge you possess. To understand how the council evaluates you, we have to look at Bloom's taxonomy, the standard framework used to classify levels of human cognition. Section 4.3 of the blueprint dictates exactly how these cognitive levels are weighted on the test. Look at the first row. The weighting for nya, or purely recalling information, is exactly 0. The weighting for heal, simply understanding a concept, is also strictly set to 0. This is the critical data point. 100% of the questions are designed at the apsang-nya, or apply level, and above. In the context of a clinical multiple-choice test, the apply level means you are given a unique patient presentation and must use your knowledge to solve that scenario. This renders traditional flashcards and the brute force memorization of disease mechanisms ineffective for scoring points. Because every single question requires active clinical reasoning, you must change the nature of your exam preparation from passive reading to active problem-solving. Now that we know how the council tests, we need to examine what specific clinical skills they are actually testing. Table 4.2 breaks down the exam competencies. Let's look at the first row, applying basic science concepts. Basic science application is heavily marginalized here. It is capped at a maximum of just 3% of your exam score. Now look at row 3. The ability to select appropriate lab tests and formulate a diagnosis accounts for 45 to 60% of the test. Right below that, pharmacology and clinical management command another 35 to 50%. When you chart this out, the math is undeniable. Diagnosis and management monopolize the exam, shrinking basic science to a statistical rounding error. When you study a disease, skip the deep pathophysiological theory. You only need to ask yourself 2 questions. How do I recognize this patient, and what is the next best step? A common mistake is dedicating equal time to all 17 organ systems. Table 4.1 outlines the precise mathematical distribution of questions across those systems. The undisputed priority is the digestive system, taking up a maximum of 16.5% of the test. The respiratory system follows, capped at 11%. Emergency medicine and cardiovascular pathology round out the critical tier, each commanding up to 10 or 11%. Just 4 systems, digestive, respiratory, emergency, and cardio, command roughly half the exam. The remaining 13 systems share what is left. Contrast that with topics like social sciences or biostatistics, which are hard-capped at a maximum of 3%. Your study schedule must reflect this asymmetry. Your calendar hours need to directly align with these percentage weights. If you have 100 hours to study, you dedicate 16 hours to the GI tract and only 3 hours to biostats. To master the high-yield topics, the strategic neglect of low-yield topics is a mathematical necessity. We can drill down even further, moving past broad organ systems directly to the precise patient presentations you will face. Section 3 of the document establishes a finite list of 128 core clinical problems. Looking again at the digestive system, we see the specific issues the council expects you to handle. You must prioritize presentations like acute diarrhea and jaundice, exactly as they are listed here. The emergency medicine section explicitly targets life-threatening scenarios. You will be tested on acute interventions, like managing cardiopulmonary arrest. If a condition is not explicitly named on this list, it is an extreme low priority for your preparation. These 128 problems act as the non-negotiable boundaries of the exam. Any study time spent outside this list is wasted effort. Abandoning the study habits you relied on throughout medical school involves friction, but the council's data demands a pivot. Quizzing yourself on what is disease X will not translate to points under this blueprint. You must adopt a method aligned with the 100% apply standard. This means consuming information through clinical vignettes, evaluating age, symptoms, and vitals. To drill the diagnosis competency, tackle questions that force you to identify a condition based on those variables. Then, drill management by solving questions that ask for the most appropriate next step in treatment. You need to source practice cases based strictly on the 128 core problems identified earlier. If you study in a group, stop reciting mechanisms. Present cases and grill each other on clinical decision-making under time pressure. Practice must mirror performance. You're preparing to make decisions under clinical pressure, not reading in a library. To recap, first, the exam demands 100% clinical application. Rote memorization is no longer a viable strategy. Second, skew your time heavily toward diagnosis and management within the digestive, respiratory, emergency, and cardiovascular systems. Third, channel your effort exclusively into mastering the 128 core clinical problems listed in the appendix. The National Medical Council's goal is to produce safe, practical clinicians ready for the ward, not academic theorists. Aligning your daily study habits with the mathematics of this blueprint is the most direct way to ensure you are meeting the Council's specific standards for licensure.